Hi, welcome, and thank you for joining us today. We are live with Dr. Torres, who will be speaking with us about vascular health. And I appreciate everyone taking part, and please feel free to submit your questions in the comments section as we go. We'll have more question time towards the end, but we'll collect them all along. Thank you. Dr. Torres?
Hi. What is vascular surgeon? What do we do? How can we help you with some of the symptoms that you could have? That could be either really something serious or it can be something very simple, just to improve your quality of life. Um, so we're basically plumbers, just of the human body. We treat two main blood vessels: the arteries, which are the blood vessels that go from the heart to all the way in the brain, the legs, the gut, and then the veins, which are the veins. Basically, what they do is take blood from all the organs back into the heart. So we treat all of them except the specific arteries of the heart. That's a cardiac surgeon. Um, but we treat every blood vessel in the body, and then space is pretty simple what happens to them. There's usually two things that happen to blood vessels. One is narrowing. So when you're born, you get perfect arteries that have no disease. And then as you age, you have diabetes, smoking, some risk factors, they can get narrow and smaller, and you can have symptoms. The other thing that happens is instead of narrowing, they can dilate and become really big. And that can be an emergency. And a lot of patients, unfortunately, don't don't have good outcomes from the aneurysms because they can rupture, and then they come as an emergency. We have to do some fancy work to try to fix it because it's very complex. Okay. um, and then this can happen all over the body. So the same thing that happens, either the narrowing or the aneurysm, which is the dilatation of the artery, can happen anywhere. It can happen in the arteries of the neck, and that can cause a stroke. It can happen in the arteries that go to the extremities, and that can cause pain when you use your extremities or when you walk, and can cause decreased flow to the gut and cause pain when you eat. And there's all these other things that we can do. We also do a lot of surgeries related to fistulas for patients that have kidney disease and require hemodialysis. We also treat those patients, and we have a big population of patients that we treat where we basically connect the veins and the arteries. As you can see, there's more of the same. You have either narrowing of the blood vessels or dilation of the blood vessels, and we treat both. But they have different symptoms. The symptoms usually of dilation of artery is it's usually pain, um, and the pain can be related, usually abdominal or in the back, and it can be a sign that it's gonna rupture soon. The issue with narrowing can present in different ways. It can have wounds, you can have pain, you can have sometimes the pain is only when you walk, and then as soon as you stop, you you don't have any pain anymore. But they can be very, very serious. So patients that have peripheral arterial disease, which is hardening of the arteries of the legs, they can have simple pain when they walk, but that can progress all the way to having what we call ischemia or starving. The muscle and the tissue die for not having enough blood supply. And the main thing with all of this is to get it early in the disease, so the patient doesn't come very extensively late when they already have gangrene or they have pain at rest. Those are what we're trying to prevent, because that can cause major amputations in the future. So we're trying to get all these disease early, as soon as the patient develops first symptoms. And then it comes to the veins. So the veins, what they do is basically they take blood from the tissues and they bring it to the heart. There's two main things that most people know about the veins, which is clots. Like you can form clots in the veins, and that clot can cause a significant amount of swelling, and it can also migrate into the lung and cause what we call a pulmonary embolism when you clogged up the main artery, the main vein that goes into the lungs, and that can be serious. And that's one of the main things that we have to deal with, because there's a lot of patients that have clots in their legs, and then it migrates to the lung, and a lot of patients die every year from it. So we treat those issues. We also treat another issue with the veins where it's called venous insufficiency, where instead of having clots form in your veins, what happens is there's these little valves that are supposed to open and close. And then at some point, either due to obesity, age, smoking, there's a lot of risk factors, even family inheritance, you can have venous insufficiency and these valves leak and they let blood go up and down, and you get swelling, you get pain, feeling of heaviness, and you can get varicose veins from it. You can even develop wounds in the future. So, but like I said, we always have to try to get all these diseases early in their stage, so they don't progress to something more serious. Like I said, we work with a lot of other specialties, uh, depending on what part of the body we treat. Um, but today I want to specifically talk about more about peripheral arterial disease because it's a disease that's very prevalent in the entire population, and it gets confused a lot with other things. So it's important, I think, for the patients to know what the difference between having pain when you walk caused by spinal disease and spinal stenosis, or when it's associated with blood flow, because it's a completely different treatment. It's a different specialist, and the worst thing that it's when patients come to me and it's a issue with the back, and I can't really give them any help or get any advice. So I try to make sure that everybody knows when to differentiate so they can go to the right specialist. So peripheral arterial disease is basically your extremities, either upper or lower. What happens is they get hardening of the arteries and they narrow until you have symptoms. Most people that have peripheral arterial disease is very mild. Um, and sometimes they have just a little bit of pain with walking. It tends to be the same length. So every time I go 4 blocks, my calf hurts. And then I rest and it gets better. But then every time I do 4 more blocks, it hurts again. And then that can progress to severe. And then it can become an issue where you have a poor wound healing, or you have frank gangrene when the toes get black, or you have pain at rest, and that's just the spectrum that can cause serious events in the future. So that's we try to get all the patients in the early stage so we can help them so they don't progress to the more serious stage. And then this one of the most important things about this slide, if there's something that everybody remembers, is to differentiate claudication from blood vessels, which again is pain usually in muscle areas. So it's usually your thighs or your calves, because the muscles, what's happening, you're walking as you walk, you need more blood flow, and then that blood flow is not getting there because you have a narrowing somewhere that's preventing that blood flow to get there. So it gets cramp, it gets pain. It's basically like a little heart attack but of the muscles. Okay, and it's not associated with pain in your joints. So pain that you have in your knee, pain that's specific to the hip, those types of pain are associated with arthritis, they're associated with orthopedic problems. This is very specific to muscle areas: calf pain, thigh pain, sometimes buttocks pain. Those are the main things that you gotta look for. It's usually very, like I said, very similar distances. Every time I go from the entrance of Walmart to the end of Walmart, I get pain in my calf. And then I have to stop. But then when I go back again, I also get pain again. So those are the types of things that are related to blood flow. There's other pains that can be very similar and they can be confused. And one of the most common that I see in the office is sciatica. And it's usually related to specific nerves that runs in the back. And it's very shooting, radiating pain that goes behind the buttocks and behind the leg all the way to the calf. Um, that type of pain, the more you do, it actually gets better. The more you stretch, there's some stretching exercises that help. So it's a little bit different in a way that the more you do it improves. There's also issues with spinal stenosis. That pain tends to get better. Some people, when they stand up, they sit down. Pain with blood flow has nothing to do when you stand up or you stand down. It also improves when you're like pushing the shopping cart in the grocery store. What happens is when you're leaning forward, the back, the angle of the back kind of like increases and it releases the tension of the nerve, and that helps with the pain. That's typical nerve issue, and it has nothing to do with the blood flow. So it's very important to learn that blood flow issue has to do when you're doing an activity, you always get pain. And then it's important to visit your primary care doctor, and then they can actually try to pinpoint where the issue can be to they can so they can send you to the right specialist. And then this is the one thing that we always try to prevent so it doesn't progress to where you develop a wound. What happens every time you get a wound, you need more blood flow. But when you don't have enough blood flow getting there, the wound gets worse and worse and worse. And these are the patients that sometimes come and it's too late to do anything for them because they waited too long. Okay. And once you have what we call critical chronic limb ischemia, when your blood flow is so decreased to your tissue, the risk of anything else happening is significant, because if your blood vessels in your legs are that diseased, that means that the arteries in your heart are probably also diseased, the arteries of your neck are also diseased, and you have higher risk of having a heart attack, higher risk of having a stroke. So it's very important that anybody that develops a wound sees a doctor, and we have to evaluate their blood flows. Very, very important. And this is very prevalent, like we talked about. It happens in all ages. Unfortunately, now it used to be of disease of the elderly above 65, but we see more patients, especially with diabetes, being in younger and younger patients. We see more patients in their 40s that come with significant peripheral vascular disease. Patients that have end-stage renal disease or chronic kidney disease also tend to have it at an early age. Um, but it tends to happen more as you age. As you age, your arteries harden more and more. Um, but nowadays, we're actually seeing it on younger patients. And this is basically what it is. It starts by an injury in the main um, entry point, and then that creates an inflammatory response, and it gets bigger and bigger and bigger, and it becomes so big that one day it just clogs up completely, and then it develops symptoms. It can come as an acute problem where it suddenly shuts off one day and you have what we call a cold leg, where there has no blood flow, you can't feel, you can't move it. Or most commonly comes as a chronic issue when you slowly develop pain and that distance that you can walk decreases significantly as the disease progresses. This is another very important slide. So the main risk factors for these are anybody that smokes or has history of smoking, and it has to do with 100 cigarettes. If you in your lifetime has smoked 100 cigarettes, you already have risk factors, because that means that you at some point could have developed an injury to the artery or the vein, and then that could continue to progress with time. Diabetes, especially if it's uncontrolled or it's been there for a long period of time, there's a lot of issues with diabetic patients who are not feeling their toes. They get neuropathy and then they get a wound, and then that wound progresses because they don't have blood flow. Age, especially like we said, above 65, high blood pressure, especially if it's uncontrolled, and then hyperlipidemia, high cholesterol, high lipids, all of that worsens the already injured artery, because it's easy to accumulate once you have your high cholesterol, high glucose. That's what happens. It gets the disease even worse. So the more of these risk factors that anybody has, the more likely to have a peripheral arterial disease or carotid disease or coronary like heart disease. So this is very important that everybody understands what are the risk factors. And then when you come to the office, we usually do some testing. The testing is very non-invasive. There's no contrast. There's no needles. It's very simple. We just put a cuff and we check your pulses and we inflate the cuff and see how much blood flow you have to the foot or the arms, and it barely hurts at all. There's no needles. It's very important. Um, and this is basically what happens. Your your arteries harden, they decrease the flow, and then you start hurting. The hurting can start to become less and less with more walking. So there's one treatment that we do with patients where we make them walk 3 to 5 times a week. And a lot of patients actually that distance increases now, doctor. In 3 months, they come back and they're like, doctor, now I can walk half a mile instead of like 4 blocks. So that's one management that we do that requires absolutely no surgery, and I see a lot of patients do well, and that's how we start most patients. After that, we decide if we have to do anything else. But what happens is, depending on where in the body that hardening of the artery occurs, it's how severe it's going to be in the future, or is it just mild that we can just treat it with conservative management. And then most people don't have any symptoms. So that's a good thing. Most people have mild disease and they have no symptoms at all. But once you develop symptoms, it's just telling you that the blockage is bad enough that it's causing you pain or discomfort or decrease the amount of walking that you can have. So it's important that once you develop symptoms, you visit your primary care physician so they can send you to the specialist. Like I said, then the first symptom is usually claudication, which is pain, and it's usually the same distance. And then once you rest, it goes away. Most patients that start with claudication, they usually don't progress to serious uh, peripheral arterial disease. And then critical limb ischemia is where you actually have gangrene or tissue loss or a wound, and that's serious. Once you develop a wound, it's you have to look for medical attention because this can result in an amputation. This can result in losing your limb. This is a serious thing. So once anybody develops a wound, it's very important they look for medical attention, either the emergency department or the PCP if you don't have any acute pain. It's just a quick quote. It's very important. The most important thing is medication. Okay, a statin, and most patients that have high cholesterol have statin. It's a very good drug. It has very little side effects. If they let me vote, I would put statin in the water, like they do with iodine and salt, but it has very little effects, and it is very good, and it prevents the progression. And if you have peripheral arterial disease and diabetes, it doesn't matter if your cholesterol or your lipids are high. The recommendation is that you be on a statin because it prevents the progression of the disease. Then there's aspirin, baby aspirin, that reduces the risk of a heart attack or a stroke. And then if you ever need any intervention in the future, we actually start another medication. But and that medication can be to a short term, long term, it all depends. But every time patients undergo an intervention, usually we start something extra other than just baby aspirin. And then modifying risk factors. The most important risk factor is smoking cessation. Smoking cessation is key. If you stop smoking, that decreases the risk of everything. Decreases the risk of having a heart attack, decreases the risk of stroke, issues with your arteries and your legs. It decreases everything. It decreases cancer, so it's very important. The other important things are controlled diabetes, and that's the number that they do every 3 months. It should be less than 7, and blood pressure control is key. Less than 140 is the goal. But again, the most important thing is smoking cessation. And then if you need help with smoking cessation, we definitely have can help you with that. There's medication, there's patches, there's a lot of things. There's even psychotherapy that we can send you to. We have smoking cessation clinics. So there's definitely help for people that need to quit smoking. And then, like we said, the first thing that we usually do is have the patient exercise so they don't need surgery. But in my experience, if you come with symptoms, about 50% of those patients at some point require an intervention, and it can be very simple. And then once you have critical limb ischemia, then that means that your limb is threatened. Around 90% of those patients will require some kind of intervention, either minimally invasive or open intervention. The technology these days is so good that I'm able to treat most patients with minimally invasive procedures, and we have all the technology available here at Riverside, and the latest in imaging, the latest in technology to clean the arteries, and the latest stents, all the latest technologies available to us. So less and less patients require open surgery and open bypasses because of the technology is getting so up to date that most patients can be treated with just a little incision in the groin. They go home the same day. They don't have to stay. And so that's one thing that we continue to progress every day. And this is basically an endovascular, just a quick, so endovascular intervention where you go in the artery and you clean it up. Uh, this is a rotor-rooter, what we call it. I tell the patients is literally that is just this device that kind of rotates and cuts the plaque out. And then most of the times we can just clean the artery, put a balloon, and that's enough. Sometimes we do need a stent that stays in, but most of the times we do it without a stent, or and everything comes out, nothing stays in. This is an example on the, you see there's no blood flow. There's only one good blood vessel on the right side, and there's severe disease throughout the artery. And then on the other image, there's blood flow. We basically created a new artery by cleaning it out with a rotor-rooter, and in this case, we put one stent. And that's basically complete revascularization, meaning you have a completely new blood flow to your leg, and it's instantaneous. As soon as you get out of the OR, that you have more blood flow. The next day, you will be able to walk more. Absolutely. And then there's some pros. Most pros, like these days, the technology is so good that I can do everything as an outpatient with a little incision and very little contrast, so we don't affect the kidneys. Um, and it's faster recovery. There's always risk with everything, but we are so good at preventing those that we have very low risk here. But it's always risk of bleeding or injuring the vessel while you're trying to fix it. But that's very minimal. It's usually less than 1% chance of that. And then there's bypass. Bypass surgery is kind of complex to explain here, but it's basically you do an incision and it's like plumbing. Instead of cleaning the artery that's already there, you do an alternative pathway with either your own vein or some grafts that we have that are made out of plastic. And there's so many data and trials and what is better, what is worse. But at the end of the day, it's whatever the patient wishes to have done and how much is affecting your life. That's the key thing from our standpoint. If it's affecting your life, then you can't do your daily activities. We should definitely do something about it. Okay.
Thank you, Dr. Torres. We have a couple questions that have come in. The first one is, you talked a lot about the narrowing of the arteries, but with the loosening and the aneurysms, are the same preventative steps the same for that, or are they different?
Absolutely. So it's all the same. So it doesn't matter if your arteries are narrowing or if they're getting dilated. The smoking cessation is the number one prevention. Um, Blood pressure control is very, very, very important. And then your statins, which control your cholesterol. But then the difference is patients with diabetes and aneurysms, most people don't know this, but having diabetes can be protective for dilation of your arteries. So most patients that have diabetes only suffer from narrowing of the arteries, not from aneurysm disease. Um, But yeah, it's basically the same prevention: blood pressure, glucose control, smoking cessation, exercise. Unfortunately, once you have an aneurysm, it tends to get bigger. There's about 20-30% of patients that get stable and it never needs treatment. But most patients, once they develop an aneurysm of significant size, it just continues to grow slowly, very slowly. You just need to monitor. As long as you monitor every year, it's usually no issues. And again, the technology is so good these days that we can treat aneurysms very minimally invasive.
We have another question that's come in. Can exercise and lifestyle modifications by themselves treat peripheral arterial disease?
Absolutely, absolutely. Just controlling your blood pressure, exercising. The more you exercise, and I have patients every week that I send and just do an exercise, which is 3 to 5 times a week, 20 to 30 minutes. Um, and that's if you have pain. Let's say you have pain at 20 minutes, you just rest, and then you finish. Then you let the pain go away, and then you restart and finish 30 minutes. And I have patients that have gone from 5 to 6 blocks to now they can do half a mile, and then I see them a couple years later, and they can do a mile, and it's completely resolved. What happens is you have a blockage, and the body is very smart and decides to do an alternative pathway to the arteries on your calf, let's say your calf, and that blood flow is enough that you can return to your daily activities just with exercise, diet, and then lifestyle modifications. Absolutely.
We have time for one last question that's come in. If you have a family history of arterial disease, is there any type of screenings we should be doing to catch it in an early stage?
Absolutely. So there's two things that we got to differentiate. If you have history of aneurysmal disease in your family, and it's usually a direct relative, either brother, sister, mom, dad, or grandparent, directly aneurysms, you should get an ultrasound. The most common aneurysm is in the abdomen, and it's just one ultrasound around when you're 50 to 55. Usually, patients less than 55 don't have aneurysms, and that's just a minimally invasive ultrasound. We check it once. If it's good, then you don't have to get any other studies in the future. For peripheral arterial disease, it has to do more about risk factors than actual um, genetic predisposition. There's some patients that are predisposed because all the family has diabetes, so they also get diabetes. Um, but most of the peripheral arterial disease has to do with smoking, high blood pressure, diabetes, and your cholesterol and your lipids. There's not as close a relationship to genetics compared to aneurysm disease, which is definitely related to family, and it's a very simple procedure for checking your blood flow to your legs. And again, if you think that your family has high risk, it's a very simple procedure. They just do a quick study and they look at your blood flow in your foot. If it looks good, that's it.
Great. Thank you so much, Dr. Torres. If anybody has questions that we weren't able to get to today, please do let us know and we will do our best to get back with you. If you would like to make an appointment with Dr. Torres or any of his partners, our office number is 757-534-5340, or you can learn more about Riverside's Heart and Vascular Services at riversideonline.com/heart. Thanks again for joining us today. Have a great day.